congratulations for the organization, which is excellent, better than Italy. So it's, let's say, an overview of electrosurgical application in cardiac intervention. Usually, when we apply electrosurgery in cardiac intervention, we usually need radio frequency, which erogates some energy, and the aim is to vaporize the water contained inside of the cell in order to bust and to facilitate the cutting or the penetration of our materials inside of some structures that we want to target. Essentially, we need energy, but we need also isolation of the materials through microcatheters or guiding catheters, and some blood displacement through the erogation of dextrose. As setup, usually what we need is also the use of high tip load core-to-tip design guide wires like the Astato X12, and some dedicated devices as well, some microcatheters and facilitated transversal techniques. So what we can do in electrosurgery applied to interventional cardiology is to favor the tissue transversal or the tissue laceration and the excision. And the applications are very wide. We can treat the aortic stenosis, the aortic valve, we can treat the mitral, we can treat also essentially the LVOT in case of obstruction, and we can also favor fenestration of dissections, as well as to explore new alternative access like the transcaval. The most important application, most famous maybe application, is the basilica that we aim to perform in case of anatomy deemed at high risk of coronary obstruction. Essentially, we can perform basilica both in native anatomy but also in case of prosthesis, and in near future, Giuseppe will confirm, we will have a lot of TAVI in TAVI with an high risk anatomy, because putting a second TH valve in the first generation TH valve, essentially we create a covered stent which can hamper the blood flow across the aortic roof. So basilica can be safely performed. Is a quite challenging procedure, but when to perform it? Essentially in very shallow anatomy with some critical cutoffs calculated at the CT scan. I want not to go deep inside of this issue, but essentially if we have our THV which is projected to be too much close to the ostia of the coronary artery, essentially we have to facilitate the lateration with the basilica technique itself. I will show you some cases, one case step by step in which we performed one basilica. The first step is to take essentially the axis and to put through a JR or multi-purpose guiding catheter as snare positioned inside of the LVOT. As a second step, we advance a system. In this case, our target was to lacerate the left cusp, so we utilized an ABU guiding catheter plus a mother-in-child with a vertebral, and we positioned the system around across the leaflet, and when we were confirmed to be in a good position both with fluoro and echo, we transversely just erogated a small amount of energy. As a second step, you have to snare the guide wire and essentially to externalize the guide wire itself, but before to do that, you have to prepare the flying V, which consists in scrubbing the Astato wire just in the middle part, just to expose the metallic part and to favor the electrification. As you can see here, we prepared the flying V, and we then delivered it just pulling and pushing. So the first operator push and the second pull, just to advance the flying V through the system that we have created. And once the flying V is in position, as you can see here, what you do is essentially to push on the catheter and to pull on the wire, but at the same time to erogate some dextrose to facilitate the laceration. And you see that just applying a small amount of push, you are able to lacerate the leaflet just in the middle, and then you proceed as usual with implantation of your TH valve. In this case, we choose the Evolut Pro Plus 23 mm inside of a mitral flow degenerated with a good result. So basilica is feasible, it's technically a bit challenging, but with a good learning curve you can essentially make it very easy to be done. There are some complications, but especially in the Euro Basilica registry, the rate of success was acceptable with an overall good survival to the procedure. The unicorn is a variation, is a simplification of the basilica. Essentially, you puncture the leaflet which is aimed to cause the obstruction, but essentially once you have targeted your leaflet, what you do is to advance a guide wire to predilate the leaflet in order to create a hole, and then you advance inside of the hole of the leaflet your valve, which usually is a balloon expandable valve like the Sapien in this case, and you see that we can appreciate the patency of the left main in this case. Cathedral is a little bit more complex and less diffuse procedure. It is usually performed when you have a big leaflet which is at high risk of prolapse. Essentially, you perform a basilica, but together with a snare, you withdraw entirely your leaflet and you create a sort of a hole. You essentially take away all the leaflet in order to proceed with the implantation of your valve, and this is related and this is performed especially in very high risk, very mobile and thickened leaflets. But electrosurgery can be also applied on the mitral valve. Essentially, mitral valve, the aim is to protect against the risk of LVOT obstruction that can happen when we do a valve-in-valve implantation, a valve-in-ring implantation, or if we go for the new prosthesis, the so-called TMVR procedures, in which you see we have a very big and very rigid system which can create a sort of obstruction at the level of the LVOT. So to mitigate the risk of LVOT obstruction, we can modify the anterior leaflet of the mitral valve, or we can target the septum, making it a little bit less thick. So let's start from the anterior mitral leaflet space plane solution. The most famous is the lampoon, in which we split the anterior leaflet. We can perform the lampoon in different way, but the most famous is the anterograde lampoon, in which you create a hole. So you do the transeptal puncture, you advance two catheters, one with a snare and the other one with your guide wire, which is electrified to make the puncture of the anterior leaflet, and once you are ready, you externalize the wire, and essentially you do the same that you do in the basilica procedure, splitting the leaflets in two. So a more easy to be done maybe and a more friendly use is the Batman technique, which is the same of the unicorn on the mitral valve. Essentially, you inflate a balloon inside of the anterior leaflet to destroy the leaflet or to create the space for the deployment of the valve itself. This is a case that we recently did. Is a case of a valve in ring in a mitral position. As you can see here, we targeted the anterior leaflet using an Agilis catheter plus multipurpose guiding catheter. Together with a fine cross and anastato, we perforated the leaflet. Then we went for a multiple inflation, we dilated the leaflet, and then we deployed the Sapien inside of the ring, and as you can see here, finally we have no obstruction at the level of the LVOT. The Detroit is a variation of the Batman. It aims to destroy literally the leaflet, because we inflate in a one-to-one fashion a balloon which create a breakage of the anterior leaflet itself, and then you proceed with the implantation of your valves. I think that this way is a little bit too aggressive, and sometimes you have the risk of embolization. The single approach is also to use the VersaCross. So this technique is used SWAT. Essentially, you perforate, you lacerate the anterior leaflet with the VersaCross, and then you do everything on these 0.35 guide wires. But another solution to mitigate the risk of obstruction is also to ablate the septum with this new technique, which is called the sesame. Essentially, you advance a guide wire inside of the septum, and then you externalize the wire, cutting the septum, and so splitting the septum in two. In this way, you mitigate the risk of obstruction. This technique has been applied both in patients with the HOCAM, but also in patients deemed at high risk of obstruction for mitral valve-in-valve, and I think that the results are very good, but the procedure has to be proctored. I think it's a little bit challenging because you have some risk related, for example, to the risk of chordal entanglement. You can also, with the electrosurgery, remove some materials. This is another case that we recently performed. This is a failure of a Pascal. You see some jets after the implantation of a Pascal in another centers. We went with a lasso, with a system very similar to the Basilic and to Lampoon, and we targeted the anterior leaflet, so we cut the anterior leaflet and we mobilized the Pascal, which remained just attached to the posterior leaflet. And then we proceeded through a transapical access to the implantation of a tendine, and you see that finally there's a bone abolishment of the regurgitation and the LVOT, which is completely patent. Other application, aortic fenestration in case of type B dissection. We did some cases in which we fenestrate essentially the type B dissection to restore the flow in some side branches. And also the transcaval TAVI for the placement, also the impella, the transcaval approach, I think is a reasonable approach if you learn how to do it. We use this approach when we have some challenges also on the transaxillary way, and we have some challenges, of course, of the transfemoral axis. What you do is to make a puncture across the vena cava to target the aorta, then you advance across the whole your delivery sheath, and once you have deployed your valve and you have finished your procedure with an Agilis catheter, you bend the Agilis catheter and you deploy a plug just to close the fenestration. You see here that in this case that we did, still there is some leakage between the aortic part and the vena cava, but you don't see any stagnation of contrast in the abdomen, so this is the most important thing. Thank you for your attention.